We have the attending physician, the hospice physician and medical director. We have registered nurses involved, home health aides, social workers, chaplains, and volunteers. And we're going to go through each one and talk a little bit about what their individual roles are. The hospice physician. Well, the patient's doctor directs care. Another myth is that you lose your doctor when you go to hospice. Well, no, that's the doctor's choice. We really encourage physicians to continue to participate in the care of hospice patients. Why? Otherwise, it feels like another level of loss and abandonment for the patient and for the family. So we really try to encourage hospice, the attending doctors to work with the hospice team right through the death of the patient. We also do have a hospice medical director with every hospice, and we also have hospice physicians. And we can, those doctors can work jointly with the primary care physicians. They have to in the certification process of the terminal illness. They also serve as symptom specialists and can be used as consults for the attending physician. And if the attending physician and the hospice feels that a home visit is necessary for the doctor to go out and make a home visit, not all attendings are able to do that, and our hospice physician is able to fill in there as well. So what do nurses do? This is probably the area that we understand most or best in hospice. Well, they assess needs. Nurses are about assessment, but they're kind of our ringleader in hospice care. They help make sure all of the different team members are brought in and are heard from, and that they help manage and coordinate that plan of care and organize our tasks. They help manage and keep an eye on the pain and symptoms and communicate with the physician about these issues when those things need to be changed. They provide hands-on care. They teach the residents, the patients, the families about the disease process, what to expect, and how to provide care. We do a lot of teaching and training of family members when care is provided at home. And they actually can be nervous at first about this function, but once they feel competent, they actually are glad to be able to participate and be a part of it. And then obviously the nurse has to listen and acknowledge any concerns in regard to care or needs for changing that plan of care. What do our social workers do? Well, they assess the psychosocial issues. They provide counseling and emotional support. They may provide non-invasive pain and symptom control techniques, music therapy, touch therapy, things of that nature, pet therapy, coordinating pet therapy in. They assist with the financial and insurance issues. Some of our patients may be wanting to see if they qualify for Medicaid. Our social workers can help them in that process, particularly if they're living in a nursing facility. They assist with advanced healthcare and funeral planning. Patients feel much better if they've put all of that in order so that, again, it's not an additional burden for the family. And frequently people don't know how to do that. And even if they're in a facility, and let's say they're in a nursing home and they have a social worker there, that social worker is so busy getting residents qualified for Medicaid and working out the family resident issues that there's not anyone really there in that environment to sit down and spend a lot of time going over advanced directives. And it takes a lot of time to really lay it out so that you know that an individual has heard what their options are and that they're making the decisions that are best for them. They provide community resources and referrals. They serve as a patient advocate. They facilitate patient-family communication towards resolution and healing and provide bereavement support. So I want to tell you a little story here about a social worker, because we'll get patients all the time. My mother was one of those. What in the world do I need a social worker for? Well, we had a patient who had been a single mom, raised her daughter. They had not gotten along well, and as soon as that daughter could, she left the house. She had been living across the country for some time when mom came down with a terminal disease. And as hospice got involved, the social worker started reaching out to that daughter. At first, the daughter wanted information, but she didn't want to be involved. But as death came closer for that patient, the social worker reached out again and said, you know, you need to come home. it's important now. This is your chance to come home. You need to do this if you're going to do it now. So the daughter did. The social worker was excited. She set up a visit to come out and meet the daughter and talk with the patient. And when she got to the door, the daughter opened up the door in tears. And she says, "Oh no, what's wrong?" And she said, "You were wrong. I should have never come home. We never got along when my mom was healthy, and it's not helping now. I'm making it worse." And so the social worker sat down on the couch with her and held her hand and said, "Okay, I know there's no going back, but let's just pretend for a moment. If you could go back and kind of wipe clean all the hurtful things your mother may have done or said to you in the course of your life, and you could do the same for the hurtful things that you may have done or said to your mother, knowing that she may only have days at this point to live, what would you want to do in the deepest recesses of your heart?" And she cried some more and said, "I'd want to crawl up in bed with my mama right now, put my arms around her, and hold her tight." And that social worker said, "Now's your chance. Now's your only chance." And so she thought about it some, and then pretty soon she went into that room and that happened. And I can tell you, as a result of that healing and that relationship, the simple "I'm sorry" and the simple "Do you forgive me?" "Yes, and I love you." That daughter was able to heal from her grief in a much more profound way than she would have ever if that wouldn't have happened. And that mother was able to die in a much more peaceful place than would have happened if that reconciliation hadn't occurred. So that's the healing that can happen with your social worker. Home health aides. They are the eyes and the ears of hospice. And because of the kind of care that they provide the most intimate care. There's not much you can hide when you're being bathed. And so that's why they're a really important component of the team. As I mentioned, they do a lot of the bathing, shampooing, shaving, grooming, and dressing, particularly as an individual's capacity to do that for themselves diminishes. They can help with feeding, providing oral hygiene, range of motion. They can do skin and nail care. It really helps the patient to conserve their energy, and they look for making sure that they're maintaining kind of a safe environment for that patient at home. And they also assist the caregivers in the care that might be there. So we frequently will find that our home health aides will notice a change in condition of our patient faster than just about everybody else on the team, even though our other team members may have gone to school a little bit longer. Very important. Okay, what do our spiritual counselors do? Well, they assess the spiritual needs of a patient. They provide spiritual care and counseling. They can help residents connect with the faith in their community. We're not there to direct a patient in their faith. We're there to meet them wherever their faith or lack of faith is and support them in their process. So it may be that Mrs. Jones was very involved in the church years ago, but as a result of her illness has not been to church in some time. Now she wants to reconnect. So we can reach out and see if her pastor will come out and do those visits, or get someone from their congregation, pastor from that religious basis, to be able to come and do that as well. We provide caring presence during critical time. You can provide for the ritual and sacraments that are necessary. They can assist in funerals, and actually do provide many funerals for our patients and families because of the bond that's created during that care. And they can provide bereavement support. I remember the pastor that came in and worked with our family allowed my mother to have communion for the first time in a long time, and spent time with my dad going through his military photos and hearing what his issues are. Now, Mom didn't like much time being spent with Dad, but Dad needed someone to spend a little time with him as well. One of the stories that I have in regard to a pastor that helps understand the need for a team in dealing with the pain, physical symptoms, psychosocial issues, was a patient that we had who we just had out of control pain. We could not control the pain at all. And what happened was finally the social worker was talking to him and saying, well, are you sure you wouldn't want to see our pastor or that? And he goes, okay, you can send the pastor out. So the pastor went out and found out that the individual had a issue that they felt very guilty about in their life and had not been able to resolve it, and it was a issue of infidelity. And his wife had already passed. There was no way to resolve it there, but they really felt a need for some resolution. And so we were able to find out that he was a Catholic. We were able to get a priest out there, and through a confession, that person finally felt relieved. And guess what? We decreased the pain meds after that, because that issue was prohibiting us from being able to get good pain and symptom management there. So even in this case, guilt was the roadblock to good pain and symptom management. But once we were able to identify that and support the patient and individual in resolving that, then we could get on with the care, and quality of life was resumed for that individual as well.